update. I'd like to welcome everyone now to their first meeting in the new year. The new year is well underway, and yeah, I hope everyone that's here is doing okay, and everyone that's been an apology is still doing okay. And we'll see how we go with updates today. Anyone in particular would like to go first to give us an update, or? I know I had my blood tests the other day and they were all fine. I've been on Eligard since April 2011, so yeah, 14 years in a couple of months. PSA is still undetectable. So yeah, so that's it for me. All blood tests were all good. Yes, Yanni. Yes, Yanni.
Can I go first since I have to leave early?
Yeah, absolutely.
So as I guess most of you know, I've been on this fun trip for about since 2011, and I've been on hormone treatment for all of that time. For the last 5 years, I've been on enzalutamide, or 6 years. And one of the consequences of all of that is bone health degradation. So I recently, in December, had a bone scan, a DEXA scan, and it indicated that I'm on the verge of popping over from osteopenia status into osteoporosis status. Now, I've been on bisphosphonate alendronic acetate for the last 5 years. So that means a pill once a week. And I've attempted to, by use of that, to stop bone density deterioration. Anyway, the endocrinologist who I saw says that she now thinks that I'm in such a situation. Oh, by the way, my PSA is fine, so everything else is fine. The endocrinologist who I saw said that she now thinks that my bone health situation is at such a state that she wants me to go on to Prolia. Now, I've done quite a bit of research on Prolia, and it's not something that I want to do because I have read, firstly, that there's a whole series of side effects that are not pretty, and also if for some reason or other I choose to cease it, then that can have catastrophic results, because it's, as I understand it, a situation where the bone building mechanism that exists within your body that it encourages falls off a cliff. So you're much more prone to bone breakages and fractures and stuff. So in particular to those of you gentlemen who have been on ADT for a long time, I'd just like to understand what sort of actions, medications you guys are taking for bone health.
Pretty simple for me, Yanni. I've had Prolia injections for every 6 months for the last 4 or 5 years.
Side effects?
Well, none that I'm aware of.
Because they make a big deal out of cardiac issues and...
Well, I had to have a heart valve replaced, but I wouldn't think that was due to the Prolia.
Well, they say there's just a sec, give me a moment.
Because I had a fair few visits to heart doctors when I had a heart valve replaced, so none of my arteries were clogged. I think the old mate that did that was amazed. He was expecting to see a whole heap of clogged arteries and couldn't find anything in them that shouldn't be there.
Back pain, blistering, crusting, irritation, itching or reddening of the skin, bloody or cloudy urine, cracked, dry or scaly skin, difficult burning or painful urination, frequent urge to urinate, muscle or bone pain, pain in arms or legs, rash, skin rash, swelling, arm or jaw pain, bloating or swelling of the face, arms, hands, lower legs or feet, body aches, pain, chest pain, discomfort, heaviness, tightness, chills, confusion, congestion, cough, difficulty with breathing, difficulty with moving, dryness or soreness of the throat, ear congestion, fast or irregular heartbeat, fever, headache, hoarseness, joint pain, loss of voice, muscle cramps, muscle stiffness, numbness or tingling, pain in the lower back, painful blisters on the trunk, pale skin, rapid weight gain, runny or stuffy nose, seizures, sneezing, stomach cramps, swollen joints, tender swollen glands in the neck, tremor, trouble swallowing, trouble breathing, unusual bleeding or bruising, unusual tiredness or weakness, unusual weight gain or loss, voice changes, and it goes on.
Yeah, well, we both, yes, Alan?
Danny, I think that list that you just read out, you could pull out for a whole bunch of medications, the sort of things that can happen, but as that list usually states, usually don't. Judy, my dearly beloved, has been on Prolia like Nev for many years to arrest and, in fact, begin to reverse osteoporosis, which in her case was quite severe when it was diagnosed with DEXA. The reading that I've done on the so-called rank L inhibitors, Prolia, and in a more severe, in a higher strength form for people with bone mets would be is available as well. There's still denosumab. All the comparisons that I've seen with zoledronic acid, which you've been using, have been positive rather than negative. I've read a fair bit about them. The only thing that's common is the fact that you've got to watch your dental risk. Any dental issues need to be fixed, but you're already in that situation with bone protective agents. So my suggestion would be, if you've been using Zometa without getting the result you want, I'd switch because if you don't like it, if something in your particular case goes off the rails, you can always switch back. But our experience here, and Nev's by the sound of it, is all positive. None of the stuff that you just read out, not one. No symptoms at all.
Well, I haven't had any symptoms that I'm aware of, and
Nev?
Yeah.
Just sorry to interrupt, but just to tell people about a new feature. If you raise your right hand, the new software will put a little yellow hand, and you can put your hand down and a little yellow hand will stay up there. It'll also give a notice on the screen, which I'll be able to tell Nev about. It looks like it's not working for Steve Cavill because he's too far back. So it has to be in the near the top right-hand side. Steve?
Top right-hand side of what?
Of the picture you're seeing of yourself. Yeah.
No.
No. Okay.
Can't get it. Paul can't get it.
It is a new feature, so if you haven't got the new software, you mightn't see it. Okay. Thanks, Nev. I'll shut up now.
You've also got access through the React icon at the bottom. If you click on that, one of the things that comes up is raise hand. So you can click on that, and Jim will be able to spot the hand raise and let us all know.
That's also new in the new version. It'll let you do things like send rockets
Mm.
Yeah.
Thanks.
Right, yeah, we got that all sorted. Or
Can
I
I
don't
just
think
say
so,
something
but
really
anyway.
quickly? I think it's a feature that you need to enable in your React button. So if you go down to the React button, it's a little feature that you have to enable. There's a little up arrow, and then it says recognize hand gestures, and you need to click on that.
Steve's having fun over there with throwing things around. He's a computer geek though. Hello, Gary GARRY. He's got his hand up. Yeah. Do you want to say something, Gary, or just experimenting?
There's one comment that occurred to me with Yanni that I mean, I agree with what Alan was saying about a lot of these medications. They often have very long lists, and it depends on the frequency, and percentages. And presumably, Yanni, if you've done your research, you know how common some of these things are, and usually they're, oftentimes the more extreme things are extremely uncommon. But I mean, obviously, the hormone therapy is the thing that's affecting your osteoporosis, or the heading that way. Whether you've thought about perhaps changing your treatment regime in some way. It's increasingly these trials now with bipolar, where you have a rest from hormone therapy for a couple of months or something like that. That could alleviate your symptoms. Just a thought.
Thanks.
Okay.
Thanks, Gary. I'll leave you, Tony. David Prestridge has got his hand up, and I'll come back to you after that, Tony. David?
Yeah, like you, Nev, I've been having Prolia injections 6 monthly for maybe 4 or 5 years, and I haven't experienced any of those long list of symptoms. Yeah.
I think every medication.
I've been having, the bone density scan every second year, and mine has, it's maintained a good level, even though it was heading the wrong way for a while there. Yeah.
Yeah, well, mine's a bit like Judy Barley. Mine's actually started to improve a bit, I think, rather than get worse from being on Prolia. So, yeah. But anyway, any other comments on that? Rightio. Yes.
Well,
sorry, Tony.
Thank you, guys. Appreciate your input.
Yeah, that's okay, Yanni. Tony?
Just a couple of comments on that. I've been on hormone treatment now since 2003, and at the start of that period, I was suffering from osteopenia, and they put me through some of the bisphosphonate type treatments at the time. And then since then, after I got off those, I got a bit of an improvement in the bone density, and I've just been taking either 1 or 2 vitamin D tablets each day ever since, and I'm maintaining my vitamin D level in the top half of the normal range by doing that. And my bone density checks, which are done every couple of years, are all coming in reasonably okay now. So I think a lot of those side effects that you mentioned are also present with old age, and I wouldn't be worried too much about them.
Thanks, Tony. Rob, if you go to Jim on YouTube, you'll be able to see a recording of this meeting. So you will. I'm not sure if you're aware of that, but it will be up in a couple of weeks' time. And all the meetings we've had are all on the YouTube channel. So just for your interest, I thought I'd mention that.
Thanks.
So no worries. So who'd like to give us an update next or tell us their story?
I think someone else had to go early, I think. Or driving from Kyneton.
Who else had to go early?
No.
Right. Okay. Well, Gary, G-A-R-R-Y. We've got a G-A-R-Y Gary and we've got a G-A-R-R-Y Gary. So we'll go to the G-A-R-R-Y Gary, if that's okay.
Yeah, I'm happy to, and
Yeah, thank you.
thanks, Nev. And it's a pleasure to be participating in the group. I'm a member of the Heidelberg Prostate Support Group, and I heard about this group through Yanni, who's also a member of that group, and he said, you know, it might be of interest to me. So thank you very much for that too, Yanni. My story goes back, I guess, to 2019. I had a prostatectomy. Not long after that, I had a biological recurrence. They weren't quite sure what was going on. So a year after that, they decided to do radiation of the pelvis. I had stereotactic radiation of external beam radiation of the pelvis for 33 days. And then plus hormone for about 12 months. I was on hormone therapy, Degarelix, and that was very good. But when I came off that, the cancer returned. And about 18 months ago, they discovered a 10 millimeter lesion in the middle of my spine at T12, which was radiated. And my PSA since the radiation treatment was a stereotactic radiation, just one lethal dose as it is. And that had an immediate impact on my PSA. It dropped from over 0.1 down to, it's currently sitting at 0.05. So quite a large drop, and it's flatlined there. It's been 18 months now, and they think it's probably reached NADA, its lowest point, and will probably start to increase again from this point onwards. So I'm kind of at the crossroads a bit about what my next treatment decision will be. I guess one thing I'm very interested to get some feedback from the group on at some point, but I understand over in the Mayo Clinic, they do liquid biopsies every time they change treatment. They don't, whereas here the standard seems to be that when you reach castration resistance, which I'm not, I'm still hormone sensitive, then they start the liquid biopsies to see if there's any gene mutations. But the thinking I've heard of from the Mayo Clinic is that your cancer matures and the genetic mutations build up over time, so that the older your cancer is, the more mutations it's likely to have, and also treatments can turbocharge the mutations. So they do liquid biopsies every 3 months, and when you get to 12 mutations, they've got BRCA1, BRCA2, and RAD1, RAD51, and all these different mutations. If you get to a cumulative of 12, then that puts you into a different category of treatment. So they tend to rely on that very heavily, I guess, because not every genetic mutation means you're going to have a nasty cancer, of course. But the more mutations you have, the more likely you are that the cancer is going to behave aggressively in the future. So I just wondered, and they do that every 3 months, or every time you have a change in treatment, they do a liquid biopsy. Over here, I've been told by my urologist is, we don't do that until you're castration resistant. So I just wondered if the guys have had any experience with liquid biopsies and how often they get them done, and have they had them done in a space where they're hormone sensitive?
Anybody got a comment to make to Gary? Yes, Alan?
Gary, there's a distinction between biopsy and testing, with genomic testing. Biopsy is pretty much used for checking out the samples from the prostate gland prior to or after surgery.
I see a liquid biopsy, which is a
Yeah,
blood.
I got that, but
Yeah.
it's kind of liquid biopsy is usually reserved for looking for what do you call little particles of tumor or DNA circulating, and taking a reading on how much of that there is. The other bit of genomic testing, which is commonly done with more blood or can sometimes be saliva, is to check out, as you mentioned, the gene abnormalities, any mutations that may have happened, and there are two categories. There's the so-called germline mutations, which you're born with, and these days, I think, rapidly approaching standard of care, that if you have metastatic cancer, it's a good time to get a genomic test done because, and it's a simple thing to do. It's no involving actually trying to sample the tumor, which is difficult to do, particularly if it's a bone tumor. So I've had one of these done. Peter Mack in Melbourne do them. You get a bit of counselling because it does have implications for your.
Were you hormone sensitive when you had it done, Alan?
No, but that wasn't the critical issue. It was whether it was metastatic, and the standard of care is metastatic disease, whether or not hormone sensitive or hormone resistant. So. The other, there's something like, give or take, 10 or 12% of people actually can have germline, the people with metastases can have germline mets. They fall into two categories, the so-called homologous repair category, which is BRCA, and a whole bunch of others associated with it. And then there's the sort that is called somatic genetic abnormalities or mutations, which typically are brought on by the treatment that you're getting, or maybe through other reasons, but it's an acquired mutation rather than one you were born with. So there's no particular protocol for those at this stage. But a number of labs do them, depending on what they find. You either again get the treatment for BRCA, which typically would be a PARP inhibitor, olaparib or talazoparib, or if it's the other category, a mismatch repair mutation, then typically you might get treatment with a PD-1 inhibitor like Keytruda or pembrolizumab. So that's how all of that seems to fit together. A bit complicated, but
I was advised that A, the test had to be ordered by a urologist, and B, there had to be evidence that I was castrate resistant, and it wasn't sufficient that I was metastatic.
Well, for me, I'd be talking to a medical oncologist at this point about managing the disease rather than a urologist.
Okay.
These guys are keeping across a different literature base, and as far as the access to testing, I'm not sure about the rules with regard to hormone sensitive or resistant. I'm not sure about that, but I certainly have had a test done and quite informative. I've had another one done actually, which is.
Was it expensive?
No, I can't remember. I can't remember what it was, but it certainly didn't cause me any alarm. The cost, it may have even been free. I've forgotten now. It was a while ago. So I've had another one done since, which is in relation to acquired thyroid cancer, which is another story. But that move toward personalised medicine is well underway now, and some of this stuff with particularly germline testing, the one you inherit, is starting to become pretty much standard of care if you're metastatic.
Thank you for that.
And any other comments to or questions of Gary? Yes, Tony Sheehan.
Yeah, Gary, I just wanted to know what liquid biopsies were about. I've not heard of that term before.
I think it's pretty much as Alan described it, you know, that they're blood tests, and they're looking for genetic mutations which can be either inherited or develop as a result of your treatments. And they're taking samples from your blood. But you know, the results of those tests, a lot of people think, oh, I'll just get it, you know, I had it done 12 months ago or 2 years ago, that should be sufficient, shouldn't it? But from what I understand, the results of these tests can change quite significantly if you vary your treatment.
Jim here, Nev, I didn't tell you that Steve put his hand up. And then
yes, sorry. Yeah, he's got a bit of light in the corner of the computer up there. Yes, Steve, sorry about that.
Gary, I was just going to say, I'll do a bit of an intro a bit later when it get a turn, but I, like you, follow a lot of American podcasts and webinars, and the only thing I would say is you have to take a lot of what they do, I was going to say with a grain of salt, that's not fair, but based on the way their medical system works, you've got to remember the doctors get paid for all the tests they order. So they order tests at the drop of a hat because they get personally reimbursed for the tests, which of course we don't do in Australia. If you order a test, the doctor doesn't get any reimbursement and the government has to pay for it. So if your medical oncologist says you don't qualify for this, then that's because generally speaking, we have a more refined system. Anyway, sometimes we're behind, but my general impression is, yeah, like they just order stuff like it's going out of fashion. And the benefit is sometimes a bit moot. So you just got to take that into account when you look at what happens in the US. That's my general commentary on the medical system.
Jim here.
Yeah.
Gary, there is a good reason for not doing liquid biopsies at your stage until you are metastatic.
I am metastatic now.
Oh, sorry. All right, well, I'll finish the point anyway. Before you're metastatic, the liquid biopsies are not very accurate at all.
Yeah.
And the other thing is liquid biopsies include anything that comes out of your body. There are urine tests and there are blood tests, and you can imagine lots of other tests you could have, but they're the two most common ones, but not before you're metastatic.
Yeah.
And my thoughts are, I mean, I agree with Steve, but my thoughts are when they're saying having any kind of tests or scans or whatever, when you change your treatments, you're not going to change your treatment that much.
I'm just coming up to the crossroads, really, where I think they are going to put me back on a combination of hormone therapy, and I had read that some of the tests can give you insights as to whether to choose darolutamide or arolutamide, you know, the different types of, you know, ibuprofen or enzalutamide, and certain genetic combinations, permutations or mutations may be more relevant to one hormone therapy than another.
Yes. Perhaps I
know that you know, for instance, you know, if you've got a poor cardio profile, then they prefer to put you on darolutamide. Other ones, you know, for example, you know, there's a tendency towards depression, or the various different side effect profiles of different hormone therapies. You've got to take that into account. But the doctor from the Mayo Clinic who talked about this strategy said that they can also be useful in informing, you know, which combination of hormones that they put you on.
Yes.
Any other questions or comments for Gary, or have you not got another question to ask Gary? Or
just a quickie, Nev, I'll just repeat.
Yes,
fact that a liquid biopsy is circulating tumour cells or circulating DNA, and it's a figure which is the count on how many such particles they actually discover, and that's helpful, but it's not at all part of the what I call the routine. It's very much research measures at this point. They're certainly not available here or in the US really for routine assessment. The other one is that either those or other tests are not really so relevant for the choice of anti-androgens either. So the distinctions between the three you mentioned, enzalutamide, apalutamide, darolutamide, which commonly used in conjunction with an injection like Lucrin or Zoladex, really the choice there would be based on their side effects in your particular health situation. So if you have a pre-existing heart condition, you might avoid Zytiga or abiraterone, for example. If you're concerned about seizures or extreme fatigue, you might avoid enzalutamide. On the face of it, darolutamide seems to have the least annoying side effects of all of them. It's the latest one to be approved, but whether those differences, how real they are, they're not based on head-to-head comparisons of these medications. So they're just based on the frequency at which the side effects occur in their respective trials. So, I'd be governed by what your medical oncologist advises.
Yeah, no, I understand what you're saying there, Alan. And the other option that I think they'll probably canvass with me is just continuing to rely on stereotactic radiation, doing PET scans to see if they can see something again and then zap it. And in that way, continue to stay off the hormone therapy, which from my experience was pretty terrible. I seem to develop every side effect you can think of with it.
Well, I've had good results with stereotactic SBRT.
Yeah.
Without doubt, metastasis-directed therapy, they call it. But I've tried going off the meds entirely when I was getting almost zero PSA for an extended period, and the cancer came back. So in spite of the SBRT, so the second round of SBRT I had was in conjunction with meds, and there's clearly, and the literature supports it, there's clearly a synergy between these meds and radiation. Either the radiation makes the meds work better or vice versa, but they work better together. So I'm now back on meds plus, as needed, SBRT, and I've only had two. I haven't had any need for one for over 18 months. So fingers crossed.
Thanks, Alan.
So Al, you went back onto abiraterone, didn't you, with prednisolone?
With actually dexamethasone. There's a small trial which showed dexamethasone to be slightly more effective than prednisone, which was the steroid use in the original abiraterone trial. Got to be careful, though. It's a very potent steroid. So if you're on it and you go off it, do it gradually.
We'll just go to Tony first, the Tony Maxwell first, Yanni, and then.
Yeah, just a couple of comments. I had stereotactic to a lesion in the lymph nodes a couple of years ago, and that's driven the PSA down to about 0.02, where it's stayed ever since. I continue on enzalutamide and Lucrin hormone treatments. I sort of prompted the idea with my medical oncologist about going off the hormones, and she was sort of like horrified. No, you've got to stay on them. And that sort of ties in a bit with what Alan was saying, I think, about the combination of the stereotactic radiation and the hormone treatments working together to sort of keep the thing under control. The only other comment I've got is there has been some use of genetic type information within cancer and within prostate cancer, as Alan was saying, I think. And I've been involved in a research project for about the last 7 years now, where they've been looking at proteins and the effect of different types of proteins on cancer and the growth of cancer and the control of cancer of all types, including prostate. And their general sort of comment is that, yes, the genomics or the genetic type information is of some use, but probably the proteins are a more fruitful area to work with in terms of controlling cancer. So I'm going to a presentation in a week or two's time with the guy who's running that program. So I'll be interested to hear what he's got to say about, because I think they're getting to the point now where they can start taking samples and making recommendations. So it'll be interesting to see what comes out of that. So I'll keep you posted.
Thanks, Tony.
Jim still has his hand raised.
Pardon?
Jim still has his hand raised.
Oh, does he? Oh, righto. There he goes.
Okay, I'll come back.
Righto. I think John Boomsma said earlier he wanted to go early. Is that true, John, or did I just dream that?
Hello?
Yeah, we can't hear you, John.
Just a second. I'll find the mute key here. I'm on a Zoom call.
No, we'll have to come back to John. Can't get him online. Rob, would you mind giving us an update on where you were at?
Yeah, sure. Yep. Look, I'm based in Toowoomba. I'm 56, just turned 56. I was diagnosed sort of late last year, October, presented to the doctor and had a pretty high PSA. It was 67. I'd never done any prior tests, so that just, I guess, came as a surprise. I didn't even know what that meant at the time. Subsequent tests of that, biopsy, I was Gleason 9. It was metastatic, present throughout my lymph nodes. I started Eligard injections in December, so I'm still in my first 3 months. So I get my next one next month. I'm on doublet therapy with darolutamide and the Eligard, and I'm also I qualified for a trial being run through the Mater in Brisbane. It's an EvoPAR trial. It's AstraZeneca, one of their PARP inhibitors, Saraparib. Now, they've done all my genetic testing, and I don't have the mutation that will necessarily respond, but I'm still decided to be part of this trial. My background is as a scientist, a plant scientist, so I like all the measurements and everything they're doing. And one of the PSMA PET showed it throughout my lymph nodes, and they did a bone scan. It was technically 2 months later, and they picked up a lesion in my spine. So I'm pretty new to all this, and I'm taking in everything that everyone's saying here. I'm quite interested, so I'm glad to be part of this group. I haven't got a lot to contribute at this point. I'm learning from others, I guess, and I will have questions over time. I guess I'm worried now about what's going on throughout my bones. I've gone through some of the previous scans, and I see lots of mentions of lesions without them calling it metastatic. Lots of foci points. Let's see what. Let's hopefully all that stuff comes to a stop.
Thanks, Rob. Any questions or comments to Rob?
Yeah.
Yes, Alan.
Rob, another thing that I'd call standard of care in a case like yours is the early use of chemotherapy, which is docetaxel almost.
Yeah.
A limited number of doses, typically about 6, and just start and then stop. in conjunction with the hormone therapy that you're having. There's some pretty solid trial evidence, and I'd say pretty much standard of care now. So if the oncologist hasn't mentioned that, and sometimes they're reluctant to, I think, because guys are afraid of chemotherapy, but a youngish guy like you are, generally side effects are very minimal, particularly early on and for the limited number of cycles. So perhaps it's worth raising that one.
And it was, Alan. It was mentioned by my oncologist in Toowoomba, and he bumped me to the MARTA to see whether I'd qualify for the clinical trial. So I'm actually in that.
Right.
Look, they'll unblind me. It's a double-blind study. If my indicators, my PSA has dropped from 67 to 1.98, so it's coming down. Yeah, I guess I won't see another set of scans for another 2 months. But if the indicators don't look good, yeah, I guess I can be pulled out of that trial. And that was what the oncologist in Toowoomba had proposed, followed by radiation therapy somewhere down the track.
Again, that tumour in your spine, if it's a single one, again, it might be subject to the trial, but there's a couple of us have mentioned targeted radiation, stereotactic radiation can be pretty powerful, particularly when it's done in conjunction with the standard hormone suppression. So that's another future treatment, maybe best done earlier than later, which you want to have a chat to your team about. You need to talk to a radio-oncologist about it, but your medical oncologist would be pretty supportive, I suspect.
Thanks, Alan. Yeah.
Any other questions to Rob? Gary, GAII, you've got your hand up.
Yeah, just endorsing really what Alan was saying too about a bit surprised that they haven't offered you chemotherapy docetaxel up front. I would have thought in your space that's a great drop in the PSA, but still they should be aiming for non-detectable, and that's what you want. And there's a very substantial body of trial evidence, as Alan said, for the use of upfront docetaxel for de novo metastatic, which is your situation.
Yeah.
Yep.
Sorry, guys, I've got to go now. So apologies for that, but thank you for your advice.
Thanks, Shani. All the best.
See you next time. Bye.
Gabriel, you got your hand up?
Yeah. I just wanted to say hi to Rob too. I'm also very new to the group. This is only my second meeting, and my story is very similar to yours. And my the difference is that my cancer was more was high volume. It was metastatic. It was quite profuse throughout my body, and I am actually currently going through chemotherapy at the moment, or docetaxel. It's too early to say. My oncologist is not willing to tell me how effective it will be. Her opinion is that it's really a combination. It's really the cocktail of the hormone therapy and the chemotherapy that is meant to be helpful. But anyhow, I just wanted to say hello and relate to you. Yeah, I'm also learning. So you're not alone in this at kind of the early stages of your cancer journey.
Thanks for sharing, Gabrielle.
We're all learning. There's no question about that. Now, Gary, GARY, come on early. He's on his phone, so we might get you to give us an update, Gary, please, and then we'll get to the other Gary in Geelong. You're on mute, Gary.
You're talking about me, Gary RR?
No, I'm talking about GARY.
Can you hear me now?
Yeah.
Oh, okay, yeah. All right. I had some scans a little while back, but they didn't show anything. My PSA has been gradually rising, and it's up to 0.34 now. So my medical oncologist has actually taken me off hormone therapy, the Leukerin, which I've been on since 2013. I think presumably to see if anything shows, and then we could zap that. And she also mentioned possible adding a second generation hormone therapy and having another PSMA PET scan. So that's my update.
Any questions or comments to Gary?
Yep.
Yes, Alan.
Sorry, I keep bouncing up all the time. But Gary, I would have thought in your case, a so-called second generation product like darolutamide or, abiraterone, one of those, is kind of routine. I wouldn't, if you've got indication of metastatic disease, you don't want to be messing around with it. You need to hit it with, both barrels. And I'd definitely come back on that one to your oncologist. Don't quote the support group as advising you what to do, by the way, but just for your own information. And you can certainly look at the various websites, not least PCFAs, to confirm these sorts of things. But I think it's a good time to be raising the question, at least. Darolutamide comes to mind, but there are others that the oncologists would be well familiar with.
Yeah, I did think the same.
The earlier comments about bone density, keep those in mind. All of these discussions we're having, anyone who's got metastatic disease should be, if they haven't already done it, getting a DEXA test and getting bone protection, either Prolia or Zometa, keeping the test going at least every 2 years. But I definitely add I talked to your doctor, I should say, about the possibility of adding one of the other anti-androgens to the Leukerin or Solidex, whichever one you're using.
Yeah,
Any
I
other?
have actually, sorry.
Yeah, you go on. You ask your question.
Yeah, okay, yeah, I have thought, about that myself, because I've seen that on other things too. She said some time ago that, putting me on a second hormone drug would cause, add to the side effects, and I think that's her reasoning. But yeah, I mean, she's supposed to be quite, well versed in prostate cancer. So yeah, I'll ask her next time. Then, yeah, sure.
Well, I think you'll find that the fact that you are doing your own research and you are asking questions upgrades the quality of the interaction between you and your doctor. I think you'll find that you should be able to talk to you about the pros and cons, and you can make a joint decision then, much better than if you're not across it all.
Any other comments to Gary? Thanks, Gary. Good luck with all that. I'm sure your treatment could possibly be improved. But anyway, that's just my opinion. Welcome, Doug. Good to see you. Now we got Gary Wall. I think you're from Geelong, Gary. Would you like to comment?
Good morning, everyone, and thank you, Nev. Look, I was invited by Yanni to come along today and to last month's presentation. We were classmates when we started secondary school together, so that was a good connection to have. Not necessarily over the best subject, but anyway. Look, I'm not quite on the bleeding edge like some of the other contributions I've heard this morning. I'm in a fairly stable situation. My prostate cancer history started in 2001 with open abdominal surgery for radical prostatectomy. 12 months later, I had the salvage radiation. And then I was chugging along quite happily, although the PSA was rising steadily. And then in 2013, I was a lung tumor on my lung was detected, so I had some surgery on my lung, and then moved on to Eligard, and I've been on Eligard ever since. Again, with that slowly rising PSA. 18 months ago, I had a second tumor detected following a PET PSMA scan. This time it was in my bone on my sternum. It was very easy to access, and I had stereotactic radiation, the SBR. And since then, at that stage, they considered that there was no need to change the Eligard treatment, that it was still proving to be effective. So I've continued on with that path for another 18 months, and my PSA is currently 0.2. And so, yeah, I haven't had to confront some of the more advanced therapies and treatments.
Just as a question, Gary, when you had your radiation, did you have any issues of radiation damage to bowel or bladder or anything like that?
Yes.
I was hoping you'd say no.
Yes, well, there's the progressive incontinence. There's things like I now use a catheter daily to, clear the effects of scarring, and sexual function that was diminished. And in 2012, so 2013, was diagnosed with bowel cancer. It's hard to know whether there's a connection there or whether that's some other hereditary causes. But yeah, I've had a bit going on since the radiation. It was all sort of what you might call slow burn stuff. It was all endured okay at the time, but the side effects gradually crept up.
Your radiation, we must say your radiation was a long time ago though now.
Yes, it was, but the progressive incontinence and things like that started, a decade ago.
Yeah. I'm sorry to hear that. Any questions or comments to Gary?
Yeah, I got one there.
Yes.
You said you had radiation in 2025. Is that right? Stereotactic radiation.
Yes, it was 2024. No, it was actually 2023. Yeah.
Right. And that was just one shot, or do you know what dose you had?
Oh, it was, no, I don't. It was conducted over a fortnight, and I think I went, sort of like Monday, Wednesday, Friday, or Monday, Friday, then Monday, Friday again.
Okay.
Yeah, I didn't.
Yeah.
I mean, it was very easy. It was a very easy part of the body to access, and and seemed to be effective.
Yeah. Because those sort of side effects that you mentioned, if with stereotactic radiation, it's usually pinpoint radiation, only one or two shots. So I'd say you've probably had what's called external beam radiation, which just is slightly different to stereotactic.
No. Yes. I've had two forms of radiation, if that's not clear. One was 12 months after the radical prostatectomy in 2001. The second SBR was in the middle of 2023. in response to the discovery of a tumour in my bone.
And that one you had quite a few cycles.
That was where I had the first set of radiation went on for about 6 or 7 weeks, and it was daily, I think, over that time. The second bout of radiation was over a period of 2 weeks, and it was quite targeted. And there were no side effects to this day from the second bout of radiation. Yeah.
Any other questions or comments to Gary?
Just a quick comment.
Yes,
on SBRT. I think most SBRT places, for the sake of safety, will tend to limit the dose per treatment, so that they don't do any collateral damage. For the two or the various treatments I've had, two of them, I had I think 60 Gray delivered in 10 instalments, and over a fortnight, a bit like Gary's. Welcome, Gary, by the way. So I had no side effects from those, whatever. But 1 or 2 would be unusual, I think. They do like to limit the amount per dose.
Thanks, Alan. Thanks, Gary. Any other questions or comments to Gary?
Yeah, just one extra comment on the stereotactic. I had a bout of that in 2022, and there were four radiations over a period of 4 or 5 days. So, and I had no side effects from that at all. So I'm reasonably, I think they're being pretty careful, given the strong nature of the radiation that they use, to really target it in on a particular area.
It's the only reason I raise it is I only had one shot, and it was 20 Gray to one spot, and they did it in one shot. And I said, would it be better to do it over 2 or 3? And my radio oncologist advised me that the success rate was better if it was given as one shot.
Well, I can't really comment on that. I don't.
It was only 20 Gray, but yeah.
I didn't query them on how many Grays they were using at the time. But I had, I think, 4 or at the most 5 radiations over a period of 4 1 week.
It may depend on where it is, Gary. Why they're able to give such a. I would have thought 20 Gray was a fairly substantial amount in one hit.
Yeah.
And I think it probably depends on where the cancer was, where the metastasis was, more than anything. So I do.
Mine was in the lymph nodes, and I've had no side effects on bowels or anything like that as a result of it.
Yeah, that's good. Paul, would you like to give us an update of where you're at, or have you got anything to report?
I can't remember what my last report was because we've had a couple of months off, but I think my last bloods were, the PSA was indetectable. So yeah, it's all going well, and I think I've got blood tests next month. So yeah, I'm on the daily hormone, so Xtanti, and the 3-monthly Goserelin. Yeah, so all going pretty well. I mean, the only, that I have a couple of side effects, obviously sexual function, and also, occasional hot flushes, but it's nothing too debilitating. So, yeah, everything's going pretty well, I would say. I've just got to watch. I'm doing a lot of the gym work, so resistance work in the gym. So which is really good, which also helps with other sporting activities. And just got to watch my food consumption. I say my appetite seems to be fairly healthy, so I'm not sure if that's more so than it was previously. But so I just got to watch the the weight around the waist.
You've got to enjoy something in life.
Yeah, absolutely. Yeah. Well, I've cut back on the beer and I just drink the red wine, but now I've been told that not too much red wine because it's got the sugar in it as well. But I'm sure I'll find something that works for me.
Good. Any questions to Paul? Comments to Paul? Yes. Oh no, you're just yeah, thumbs up. Yeah, good.
Yeah.
That sounds like everything's going okay in your world at the moment, Paul, which is good.
Yeah, just booking holidays as we do. The obviously the health insurance holiday insurance is a lot more expensive these days. But that's a small price to pay for covering myself. When we go overseas, just in case I need any treatment or anything like that, or need to be admitted to any hospital or whatever. So
actually, I do have a question to Paul. So you answered the question. So you're traveling overseas and you're able to get health insurance, okay?
Yeah, we like Bali. So for 2 weeks in Bali, it's about for my wife and I think it's about $1,000. So it's compared to what it was previously, 200 and whatever. So it's significant. But last time we had to use it because I was getting I think in hindsight I might have had COVID, but I had this swollen glands and that, so you're never quite sure. So it was great to have access to the international hospital over there. The excess is typically it's $250, I think. So we just pay the excess, and then the balance was only another couple hundred, $230 or something like that. So yeah, I mean it's just something we factor in now. So, but I think it's third world country. Obviously, it's important to have access to international hospital.
Doug?
I'm just wondering whether you declared that you had prostate cancer or advanced prostate cancer, because one of my colleagues in the Heidelberg group had a lot of trouble getting health insurance. He was honest. He declared that he did have advanced prostate cancer and he was on hormone therapy, and quite a few of the insurance companies said, well, we won't insure you.
Yeah. My wife looked after it. So she said I had it and I had like lymph nodes, but it was in remission, and I wasn't getting any treatment like radiation treatment at the moment for it. So that was with Covermore. Yeah, so I'm not sure if they're a preferred provider, but yeah, so that's I don't think my wife had too many issues, organising it.
Doug Mickeljohn, you wanted to say something?
Well, yeah, well, actually, Paul answered the question. I wanted to know who the insurer was, so it's Covermore. Thank you.
Covermore, yeah.
Thanks for that, everyone. Any other questions for Paul? Righto, Steve, do you going to give us an update or?
Yeah, sure. In fact, because so many people ask questions, I thought I might give a quick intro. I was a member of this group decades ago, if you recall, but I'm also in the Geelong group along with Gary and Alan, and our meetings tend to conflict, so I haven't been here for a while. So I'm an old member and new member. I was diagnosed in 2012 with de novo metastatic disease, meaning it was metastatic in my spine to start with. And I've kind of had a menu of pretty well everything that people have mentioned so far, except a prostatectomy. I went straight onto hormone treatment, and I've had, I think, 4 or 5 different sessions of stereotactic radiation over the 12 years. I did chemotherapy in 2017, and I've been on hormone treatment on and off for the 12 years as well. So I've had 3 holidays from drug treatment. First one was after about 18 months. I had done external beam radiation to my prostate and stereotactic radiation to my spine. And then, I don't know, after about 18 months, my PSA was undetectable. And I said to the radiation oncologist, and people have said this already, I've had enough of these side effects. It's driving me nuts. So I said, I want to stop. And he said, okay. So I stopped. And then it came back maybe 18 months later, and PSMA scan showed a couple of spots. I did it again. And that was less effective. So then I followed that up with chemo. To answer some questions about chemo, at the time, it was debatable whether it was a good idea or not for low volume disease like mine. And in fact, I spoke personally to the doctor in charge of the Stampede trial from the UK, whose data showed that you should do chemotherapy, and the other trial charted said you shouldn't for low volume. So I did it anyway because I thought I wanted to do something. But I bumped into him at a conference last year, and I said, oh yeah, based on what you said, I did it. And he said, yeah, we wouldn't do that today. Because for low volume disease, they tend to not do it. It worked for me because I had 7 years off ADD. And I have just gone back on it. But I've been on it for 3-4 months, and I've just started my little mini 4th holiday from drugs because I'm going to Europe next month for a holiday. And I said to my oncologist, man, I'm so tired all the time. Like I'm on the injections, the Zoladex, however you pronounce that, goserelin, and I'm also taking darolutamide, and especially the darolutamide, that just smashed me. Like I'm done by lunchtime every day. So I said, I don't want to go to Europe feeling like this. So I said, I just want to stop. And my wife wasn't very keen on that idea. She thought, oh, I don't want you to stop. And the doctor looked sort of like ambivalent. And my wife said, you don't think this is a good idea, do you? And the doctor said, and I love this, she said, it's your body. Like you need to make the decision what's best for you. So I've stopped the tablets when they ran out, the last script, and I'm meant to have my injection, I think like today. And I'm not getting it, although the doctor did schedule me. She said, when do you get back? And I said, 21st of March. And she said, what day of the week's that? Friday. She said, right, the following Tuesday, I'll book you in for the injection. But actually, I'm going to get my PSA tested before that. And if it's still undetectable, I'll say, no, I'll just put it off. So, yes, I've had a bit of everything. And to answer that question on stereotactic, I've had my original radiation to my prostate was 20 sessions. So that was shortened already. And then I've had 5 doses, and I've had 3 doses, but I've never had 1 dose. And in fact, they were going to do 5 doses to one of my lymph nodes. But then when I went in for the treatment, he said, actually, we're going to do 10 because the stuff that was in the way, he said it's going to, the risk is too high. But if you've got like a spot, the one that was on my T4 spine, they hit that with like, I think 3 doses of like total of, I don't know, 30 gray or something. So like 10 or 15 each time because there's nothing to hit except your spinal cord. That did worry me a bit. It's your spinal cord's like there. But, if it's in your hip bone or something, there's not much to hit. So anyway, that's been my experience. Apart from fatigue, people ask me, how are you? And I'm going, I'm still here. It's 12 years later. I thought when my urologist told us after our first appointment 12 years ago, he told us to go home and tidy up our affairs. So, and I just had, me personally, but we've just had our first grandchild a week ago. And I didn't think I'd be alive to see that. So I'm very happy to still be here. So
Thanks very much for that, Steve. Any questions for Steve? Yes, Gary?
Yeah, just great to hear that Steve's very much in control of joint decision-making process on your treatment there. So well done to you for that. Just on the issue of chemotherapy where you have low volume disease, and I know that in the literature there seems to be quite a bit of debate about this. I'd be interested what the group thinks generally on the question, because I'm contemplating combining my stereotactic radiation with chemotherapy, even though I'm low volume. And one of the doctors that I watched on YouTube said, look, chemotherapy actually kills the cancer. All these hormone therapies, they send it to sleep. They don't kill it. They send it to sleep. Chemotherapy doesn't kill all the cancer, but it's got a much better chance of doing that job. And so he was a strong advocate of chemotherapy for low volume as well as high volume. So I just wondered what people think about that.
Look, my reading, because I did pay a lot of attention to that, and as I said, back in 2017, it was interesting. My doctor said, yes, let's do the chemo, and then literally went into the appointment a few months later to schedule it. And he said, oh, I've changed my mind. We won't do it because low volume, blah, blah, blah. Anyway, I wasn't very happy with that. So I actually wrote to the researchers and got answers from them and went back, to my next meeting a month later and said, no, I do want to do it. And he said, oh, why? And I said, because I wrote to the researchers. And he said, oh, of course he did. Because he got used to me, like, being in touch. Anyway, and as I said, I actually literally personally spoke to the guy who did the Stampede trial about a year ago. And he said they have kind of changed because the data shows that an ARPI plus injection, second, like darolutamide or whatever, plus, is giving as good results or better than adding docetaxel. But I'd have to say that if you're happy to put up with all three, like, you shouldn't do docetaxel instead of the ARPI, like darolutamide or whatever. But if you're happy to put up with all three, I'm kind of a bit like you. I'm going, there was a guy called Gang or something a few years ago who was of the belief that you hit it with everything. I remember him at a conference saying, if you've got a house on fire and you've got 4 different fire trucks, you don't line them up one after the other. You just hit it all at once. So I thought, yeah, that's a good analogy. So if you're young and fit, proviso, I never went back to work after chemo. It hit me so hard. I didn't go back to work. But I'm unusual, and I think maybe has anyone got any view on this? I was so sick from chemo because it just smashed me, but it clearly smashed the cancer as well. Like, I wonder if there's a correlation. The sicker you get, the better a job it's doing. Don't know.
And did the chemo effect, did you recover from that? Whereas the hormone effect, it's just ongoing, isn't it?
That's true, but my side effects from the chemo have been ongoing, like brain fog and fatigue. Kind of never got better. I mean, clearly better. But yes, I like stopping. I've had the opportunity to stop for 7 years, and I put that down to the chemo. So, if you feel confident, doctors don't like prescribing it because it's nasty. Whereas the ARPIs, overall, anyway, that's I'll let other people talk.
Yeah, thanks very much, Steve. You've always taken a great interest in your treatment, I know, and well done. Now, Alan.
Just a quickie, Steve. I think the effects, depending on age, but the effects of chemo are pretty variable depending on the individual. The literature I've read says that younger people often have very few, if any, symptoms from a limited course of docetaxel. So those on the panel here just need to, decide whether to have a go or not. I think the literature also says there's not much difference between using, second generation anti-androgen or particularly something like abiraterone or chemotherapy. The results tend to be similar in conjunction with Solidex or Lucrin. The cost obviously is lower, the cost to the public purse with Taxotere, and that's with docetaxel, and that's one of the pluses. And that's why it's often recommended in countries that don't have the support that we have here. So just a matter of suck it and see. I'd say younger people have got a pretty good chance of being unaffected by it. Steve was a bit unlucky, I think.
Thanks, Alan. I'd just like to get to a couple others that haven't told their story today, and David's one.
Gabriel's got his hand up. Gabriel's got his hand up.
Oh, sorry. I can't even find Gabriel. Oh, here he is.
Yeah, thanks. Thank you for whoever said that. I just wanted to put something to the group because we're talking about chemotherapy. The analogy was given to me when I was first diagnosed and has been reiterated to me. So I was the oncologist that I saw was the locum that works with the oncologist, and then the oncologist who happens to be professor and was head of oncology, at the treatment center that I'm going to. So, very knowledgeable person. But the analogy that they used, it just doesn't work for me. They said that basically they give me a cake, and the body of the cake is the 3 monthly leucorin injections. The cream in the cake, or the icing on the cake, is the darolutamide, because I had high volume metastatic cancer. And then they say the sprinkles, which to me, a sprinkle is something which you take it or leave it, is the chemotherapy. But which is, I've found, a ridiculous kind of analogy. And it just doesn't work for me, particularly as I had to actually have a prosthesis put in because the cancer was so bad in my left femur. I had osteosurgeon, so orthopedic surgeon, operate and take 17 centimeters out of my left femur. So I had to recover from that operation. And then, so my chemotherapy came a little bit later, not within that kind of 3-window month of starting the hormone therapy. But I guess what I'm asking is, why would you refer to chemotherapy as a sprinkle? Because that to me is, take it or leave it. It seems to be a very, very important part, particularly if it's going to kill the cancer. I'd like to push back a little bit and maybe ask my oncologist if she could find a better analogy. I don't know if there are any comments on that.
I don't think the analogy matters much. What matters is the data, right?
Sure, but I love metaphors. I'm not a scientific person. So to me, I could take it or leave it. I can take or leave sprinkles. Anyhow, look, if it's not a big deal for other people, I just wondered if there were any comments.
Any other comments? We're starting to get close to time. David, if you'd like to give us an update on your treatment, please.
Yes, thank you, Nev. So I've my journey started in 2013. Radical prostatectomy, hormone treatment for up until it started to fail, maybe 18 months ago, 2 years, no, longer than that. When it started to fail, I went on to enzalutamide, and that brought it back down, not to undetectable again, but very low. And then over the last 2 years, that my PSA has been just rising really slowly, and eventually got to 0.2 about October last year. And so I had a PSMA PET scan, and it detected one lesion on my third rib. And so I had 2 doses of radiotherapy, 22 gray, a day apart. Like one a Monday, one a Wednesday, and that was the week before Christmas. And so yesterday I returned after having a PSA test to see what had happened. And so my PSA had only dropped from 0.27, which was the latest PSA test at the time I had the radiotherapy, to 0.2. So it had only dropped 0.07 in the 7 weeks since I've had the treatment. So I'm just curious to know what you guys know about how long would I expect, what would the wait time be between having the radiotherapy to, the lowest that the PSA might drop to. And I've got another question after this one as well.
Any comments of how long it might take? Yes, Alan?
Just a quickie on the first question. There are two aspects to it. One is it does take a finite amount of time for radiation to knock off the DNA in your cancer cells. So if you're too quick off the mark with the PSA, you might be disappointed. Give it a little bit of time. Second one is, and I guess the other thing is, 2 consecutive results will give you a sense of direction, which way it's going, more than a single test. The second one is that the PSMA PET scan sensitivity depends on the PSA result to a fair degree. So I would have thought that a PSA of anything too much less than 0.3 is not going to detect much more than half the number of METs that you may have as the PSA goes up. In other words, as you wait a little bit longer to get your PET scan done, you're more likely to discover other METs, could be small and slowly progressing, but they're there, which you may not otherwise pick up on a PSMA PET done too soon. So, maybe next time you have one done, wait and talk to the doctors, of course, about waiting till it gets to, I don't know, 0.5 or even 1. They're still very low figures. And if it's rising slowly, there's no reason to panic about it. But you're more likely to get all the mischievous little ones instead of just some of them.
Okay. Yeah. No, that's
Gary?
nice.
Can I say, Nev? When I had mine, I asked that specific question to my radio oncologist, and he said it will continue to decline for 12 to 18 months. So don't lose hope because you've only had a moderate decline in your first PSA. If that was 3 months ago or even 6 months ago,
it was only 7 weeks ago.
Yes, well, that's the good result, really. And I would suspect, certainly with my case anyway, that was my PSA continued to drop. And it's like a bell-shaped curve. It drops fairly significantly and then it continues to drop, but it then flattens out. And it continued to drop for 18 months.
Okay.
So you haven't reached NADA yet by any stretch of the imagination. But I do endorse Alan's comment too that, you can, at 0.2, obviously the higher the PSA when you actually have the radiation, the more likely they are to discover other METs, because PSMA PET scans are not, they're not 100%. There could be micro METs still floating around there, but certainly don't lose hope because you've just had one result that's less than, if it continues to decline, it should, and should do so for at least 12 to 18 months.
Okay, no, that's great. And my other question,
yes,
my other question, over this same time period, I've talked about that, it's been rising. My PSA has been rising slightly. I haven't had very many testosterone tests. Not each time I've had a PSA test, but my testosterone level has also risen from what I believe is the best place to be around, or 0.5. It slowly moved up to 1, and so the radio oncologist suggested that I change from Eligard to Zoladex, and she suggested that just 1 week before my 3-month Eligard injection was due. So I did that, and so since since I've made the change, it's nowhere near 3 months yet. My testosterone level went from 1 to 0.8, so it's dropped. And I haven't ever heard of people after, I've been on Eligard for probably nine years. Does anyone have a comment about changing after all that time and noticing a difference like I've just experienced?
Anyone want to comment on that? Changing hormone treatment? people do change hormone treatments all the time, but probably not for the reason you're talking about. Sorry, David, we can't help.
Thank you. Well, it's certainly, it's moved my testosterone level lower, in a short time. So see what happens there.
See what happens. Yeah, appreciate
Thank
that.
you.
Nev, Tony,
Thanks, everybody.
Tony here again. Can I just add in something on the original point that David made?
Yeah.
I was on I'm still on enzalutamide, and my PSA was coming back up from the NADA on that, and it came back up to about 15, something of that order. And I then had the doses of stereotactic, radiation, and it sort of hung there at 15 for longer than 7 weeks. It was wasn't doing very much for a while, and then it suddenly took off and started going down, and then it rocketed down to about 0.02, where it's been for the last couple of years. So I wouldn't be too worried about the fact that it's taking a little bit of time for the radiation effect to kick in.
Thanks, Tony. Any other questions or comments for David? Rightio. Yes, Gary?
Just on the issue of changing hormone therapies, of course, the bottom line is it's the lowering of the testosterone that produces the results. So sometimes when you move from, say, Eligard's Zoladex or to one of the other hormone therapies or a second generation hormone therapy, it can be more effective in lowering your testosterone, and that in turn results in a drop in the PSA. So that's what it's really all about with those first, second generation hormone therapies, is keeping your testosterone down. That's what produces the side effects, and that's what produces the results.
Yep, unfortunately, that's right.
Yeah.
I think a figure of 0.5 millimoles or whatever the measure is a good target for testosterone. You want to keep it down.
Yep, absolutely. Now, earlier I posed the question of how many stages of prostate cancer there are, because Pete wants to know, because he saw on PCFA Facebook page the other day where someone claimed to have the 5th stage of prostate cancer, and he thought there was only 4. So can someone enlighten me on just how many stages of prostate cancer there are? Is there 4 or is there 5?
Nev, I've heard people say that before, and I don't know what system they're using, but the TNM staging system is pretty clear. There's stage 1, 2, 3, 4. 4 is metastatic. I think sometimes when people say that, I think they're confusing it with the ISUP grade group from your Gleason score. So when you've got a grade group 5, which I had, for example, that's your grade group. So I was stage 4, grade group 5. And I think when people say 5, that's what they mean. But I have literally had this argument with people like on Facebook, and they just won't be convinced. You can send them the
5. Yeah.
I think that's where the 5 comes from, and it makes sense because that's the worst grade.
That's right. Yeah.
I think that's what they mean, and it's not hard to muddle up, like stage grade. Like if it's the first, I remember the first time I went to the doctor. I don't know if anyone else was like this. I went to the doctor because of to get my blood sugar checked, and he told me I had a fine blood sugar. My PSA was 20, and I said, "Okay, what's PSA?" And then prostate. What's my prostate? I don't know what it was. And I said, "What should it be?" And he said, like it was 20. And I said, "All right, what should it be?" And he said, 2. I went, "No, that doesn't sound very good." And I said, "What does that mean?" And he said, "It means I'll have to ask you to drop your pants while I put on a pair of gloves." But, the first time through, you're going, "What are you talking about? What is all this?" Yeah,
it's a bit of a shock to some people when they get diagnosed with prostate cancer.
Out of nowhere.
There's no surprise there, eh? Doug, have you got anything to update us about? Doug Meiklejohn? Oh.
No, well, I'm going well, but it's interesting about the PSMA and the etc. I'll be quick. Initial diagnosis, my PSA went from 4.4 to 5.6. Had a biopsy February 12, surgery October 12. PSA post-surgery was 0.02. I think the surgeon said to me, "Oh, it might keep going, it might go down lower than that," but it kept going up. And at 0.06, that was a trigger for radiation. I had 33 at 2 grey, kept going up, so that was outside the bed. I had PSMA PET in January 15. They said there was something suggestive, and have another one a few months later. So in June, it was confirmed I had a 2 millimetre, probably in the lymph nodes. I guess it's the lymph nodes in the left side, down low on the left. So from June 15 to October 15, went from 0.38 to 1.4. So I started, had chemo and hormone, the stampede stuff. In October, it had reached 1.8. So in December, it had gone to 0.03, and kept going down. In January, it was 0.15, and through to April 16, less than 0.008, and I've been less than 0.008 since then. But I had a non-Hodgkin's lymphoma diagnosed, we'll say March 2023, had chemo for that, and in remission there. But then I had what we'd call I had a myocardial infarct, but no obstructive arteries, they say, in September 23. And I've got had the angiograms, one 50% and one 30%. Not enough to stent, and that's probably the part that is causing me grief in getting travel insurance. I think that if I'd had stents, they may look at me more kindly in relation to the heart. Although I've been hypertensive since age 22, and I think that's where I say I'm fortunate. I've been to the doctor all the way through, and they started checking my PSA at age 50. So, I'm very happy to be here.
Thanks very much for that, Doug. Appreciate that.
Thanks, Deb. Thank you.
Any quick questions to Doug? Comments? Now, I haven't got to Tony Sheehan or George. Oh, Brendan's turned up. I haven't got to him either. Tony, have you got anything quick to say? Are you still doing okay, or?
Yeah, sort of travelling along sort of more or less as I was. But I do have a question for the group, and it's about a new drug that's been listed on the PBS. It's called talozparib. I don't know if anyone's familiar with it, but it's a PARP inhibitor, and it's a drug that people use in combination with enzalutamide Xtandi. I was wondering if anyone within the group has got any information on this or have had access to it.
Any comments? Yes.
A PARP inhibitor is fairly specifically aimed at a mutation called BRCA, a breast cancer gene that occurs in males as well, which is tends to send the prostate cancer in the wrong direction. If you've been diagnosed, or let's say you've been checked genomically to have a BRCA gene mutation, then olaparib or talazoparib or one of the other aparibs, which are all PARP inhibitors, are likely to be effective. The rules are specific for the particular PARP inhibitor. There's 2 or 3 of them. So you need to talk to your oncologist about that. But a genomic test is generally part of the deal in accessing those.
Thanks, Alan. Yeah.
Yeah, I understand that. Can I speak, Nev?
Yeah, yes, Tony.
Yeah, I understand that you have to be positive for BRCA1 or BRCA2 mutations, but I'm just sort of wondering at what stage would you start using this drug? What sort of things would you be experiencing with the cancer to cause you to look at that alternative?
It'd probably be a bit related to the rate of increase of your PSA and the the grade that you originally had with your grade group or Gleason score. They're the sorts of things that an oncologist would think about. Plus, of course, any symptoms you may have. I don't think there's any other rule of thumb. If you are BRCA positive, then the likelihood is that that the PSA will continue to rise as the tumour gets a bit more aggressive. So at what point to intervene, don't know.
Thanks, Alan. Any other comments? Brendan, have you come in late? Have you got a quick word?
I just finished radiotherapy this week and everything's looking good. So yeah, no, I'm fairly happy with where I am at the moment.
How long have you been on treatment?
ADT for 5 months.
Right. All good then. And you're tolerating that okay?
Yeah, wake up a lot during the night, but with the hot flushes, but otherwise okay.
Right. How do you go with physical work? Can you do that okay if you have to, or does that?
Yeah, no problem there.
Yeah, good, good.
The hot flushes, think about using a fan at night, that helps. Just looking over. Just a little bit of air movement makes all the difference.
Yeah. George, are you doing okay down in Dubbo? Are you ready to welcome us all?
Yes, I'm going okay, thanks.
Yeah, good.
Flat out.
Not having any treatment other than what you've been on for years?
Yeah, no, I'm still on the Zoladex. Testosterone's down to nearly nothing. And I'm cutting a tree down this afternoon, so.
It's all good.
All good, yep.
Rightio. Well, if no one else has got any questions or comments, we might wind it up because we've gone a little bit over time. So anybody else got a question or comment?
I've got one more comment. Thanks, Nev.
Yeah, right, Doug.
I've got down the PSMA report, and that was in close to the hip bone, so it's down the nodes there. I did ask about stereotactic radiation, but they said too close to the ureter, you might fry your ureter, and
right.
I wasn't keen on having a bag, so.
Yeah, no, I can understand that.
Like chemo, etc.
The option.
Knocked it out. Thank you.
Thanks very much, Doug. Yes, Steve?
Actually, quickly, because somebody brought it up a minute ago, I thought I'd mention on the insurance thing. Yes, I'm in the process of getting insurance for this Europe trip, and nobody will cover metastatic prostate cancer. They always exclude it. But then but I don't care, because like, what's going to happen when I've got metastatic prostate cancer? But the thing is, you've just got to look at the policy that says if they exclude everything. So somebody says, because we won't cover prostate cancer, we won't cover you at all. And other policies say, we won't cover that, but we will cover anything else. Like I've got diabetes and high cholesterol and shit as well, and they will cover that. So you just got to read the fine print that says, like, so the credit card insurance, my Amex says no. Like, you're not covered at all. But anyway, so and I'm filtering down the list. When I finish, I might I'll talk about it next month. I'll work out how I came up with the short list. My wife's got long COVID, so it's a short list between her and me. Anyway, but just look at the fine print and say, as long as you exclude the cancer, will you cover everything else?
There's a bit of research involved. There's no question about
it's a very slow process.
yeah. Thanks for that, Steve.
Steve,
right, thank you everybody for your attendance today. Appreciate it. All the best. Bye.
Thank you all. Bye-bye.
Steve, can you send me a copy of your shortlist?
Yes, I will.
Thank you. Thank you.
Bye-bye, everyone. This is the end.
Bye.